So I have Dr. Sheng. She's my partner in melanoma oncology, and sees our patients with melanoma. And here she is.
Right here, if it's okay. Is there a microphone here? Okay, great. So thanks for the introduction. That was a fantastic talk, Dr. Schwartz. So my name's Sheng. I'm one of the medical oncologists over at Sideman. I practice in Avon and also downtown at main campus. So today's talk's going to be on what do we do now if your melanoma has spread to other locations? So we're going to talk about what this means, what the workup could look like, and what the potential treatments could be. I'm hoping at the end of the talk that you know that there's a lot of hope. And that's why me and Dr. Mangla especially push towards getting our patients through therapy, because we can see that the outcomes can still be really, really good. So for a little bit of background, melanoma is the most lethal form of skin cancer. It can spread to all areas of the body. Unlike other cancers, it does have a proclivity for the brain as well, which makes melanoma a little bit special. The big risk factors that Dr. Schwartz also alluded to is UV exposure, but also some family history, lighter skin and eye color, as well as age. The American Cancer Society did a study that looked at the 5-year relative survival, and it shows that still now for patients with stage 4 melanoma, the overall survival is around 35%, but as we move the needle with having more patients go on immunotherapy and other targeted therapies, this is starting to become better, these numbers. So what workup can you expect if your doctor tells you, hey, I think that you have melanoma and I'm worried that it might have gone somewhere else. Maybe you're coming up with a symptom that makes them worried, like shortness of breath or some belly pain or maybe some numbness or weakness somewhere. So you can expect that we'll be getting labs, something called lactate dehydrogenase. I'll explain what all this means in a second. We'll also get some pictures to see where has it potentially moved to in the body. And that's a scan of the entire body, typically a PET scan that looks at activity levels in the body of cells that are turning over very quickly. We think about cancers being these aggressive cells that they're going to be dividing very fast because they're sort of these superior cells sort of dividing in your body. But we also can get CAT scans as well and look at the entire body if we can't get a PET scan. We'll also get an MRI of the brain as well to see whether or not there could be any spots there that could explain symptoms, or maybe you don't have any symptoms, it's just something that's starting to form. And then lastly, if possible, we always want a biopsy of one of these other sites or satellite sites, because while we do know that you possibly have the melanoma based off of the skin, we want to make sure that it's not anything else. And we take that tissue and then we can send it for mutation testing. And that's really important to drive what options you have for later. So Dr. Schwartz talked a lot about mutations and why are they important. How I always say is I take a step back and say, what is cancer in general? All cancer is a cell that was normal, in this case a melanocyte, a pigmented cell, skin cell, and when it went to go divide, it made an error in its DNA. And when that happens, your body's supposed to say, oh, that doesn't look right, and get rid of it. Well, what happens when these cells don't get rid of your immune system doesn't get rid of these cells? These cells start to divide more, get more mutations, and eventually becomes a cancer cell. And we know that melanoma cells especially can have certain mutations that develop, and eventually we know that some of these mutations can be targeted by certain therapies. So it just gives us more options and characterization of the cancer that you have. So what does this workup really tell us, right? We tell you to do all these tests, you're already nervous, you're coming into our office, and we're saying, oh, well, let's take a break, and why don't you go do all these tests? And you're just like, why can't I just get started with therapy? Why do we need to do all these things? And it's because, one, we want to see where is the tumor. We know that patients who have multiple brain lesions, especially if they have symptoms associated, like numbness, tingling, motor issues, sensory issues, headaches, they do worse with our therapies. We also know that if you have a lot of tumor sites, not just one or two, that also pose a bad prognosis. And if you have an elevated LDH, which is that blood test, which is a marker of how fast those cells are dividing, if that's really high, then we also know that your cancer is probably a little bit more aggressive, and also makes us a little bit worried that we got to get you to therapy pretty quickly. This workup also now tells us whether or not you're a candidate for some more local therapies where we can actually shorten the duration of medical therapies that you'll be on. So now you're told that you have stage 4 melanoma that's spread to other parts of your body. So this is sort of how I think about patients when they come into my clinic. So the first question I always think about is, well, are they an immunotherapy candidate? So going back, what is the function of your immune system? There's lots of functions, but the two big ones are your immune system is supposed to identify any cells that aren't yourself. So we traditionally think of bacteria, parasites, viruses. Your immune system also is supposed to recognize any cell that's not perfectly like yourself and get rid of it. And its also second function is for healing. So we know that melanoma cells sort of put this brake system, like Dr. Schwartz alluded to, that prevents the immune system from actually doing its job, recognizing these cells. And so therefore these melanoma cells are able to continue to divide and become more and more aggressive over time. And this is sort of this dynamic, once again, of showing that as tumors all start from that one cell, like we talked about earlier, but over time they become a little bit different, just like you're not like your siblings and your siblings aren't like your children aren't like your nieces and nephews aren't like yourself, and the grandchildren are different. I say cancer cells are the same as well. So over time, they all get different characteristics, and some are a little bit better than others. And the ones that are better or more advantageous start to develop and grow and seed to other places. Melanoma starts at the surface of the skin. So over time, your cancer cells are like, well, why am I stuck on the skin? There's not a lot of space here. There's not a lot of resources here. Why don't I go deeper into the body and spread to other areas? And so we know that cancer cells in general, both locally, regionally, and globally, sort of suppress or evade the immune system in multiple different ways. So how does immunotherapy work? It takes that brake off your immune system. So when your immune system is globally activated, it goes back and says, wait, that cell doesn't look right. Let me try to get rid of it now. And there's lots of different agents that we'll talk about in a second. But when the immune system's activated, it's not against just the cancer, which is what we would hope for. It actually just globally activates the immune system, so it's just heightened everywhere. And so that's why, while I don't personally feel like the drugs themselves are that toxic, unlike like chemotherapy, which we traditionally think of for other cancers, it does have its certain types of side effects, because it just depends if the immune system, when we like that match with the immunotherapy, gets too activated or just gets a little bit activated. So if it gets too activated, it can really attack any place within the body. Sometimes it can misfire and misread healthy cells as unhealthy cells. So that's where, when you look at your MI chart, you'll see all the itises that might appear throughout your patient chart. And itis just means inflammation. So you get inflammation of the liver causing hepatitis. You can have inflammation of the kidney, nephritis, inflammation of the heart, myocarditis. And so really any place in the body can really be affected. So that's why we really have to think about, well, who can really qualify for immunotherapy? Really, I think are you healthy and fit? Are you someone who's biking, who's able to cook and clean, able to bathe yourself? Are you able to do most things independently, or do you require someone to help you? That's how I see it. Are you fit, or maybe a little bit less fit? And also the reasons why can't you do those things if you're not doing them independently? I also think about you globally as, like what other medical illnesses do you have? What are your other medications that you're on? Because if you're on a lot of things, you have a lot of subspecialists and they're having a hard time controlling lots of different parts of your health, you might not be able to withstand the therapies if you were potentially to get one of these side effects. And then especially patients with autoimmune conditions like Crohn's disease, lupus, ulcerative colitis, they weren't included in any of the studies that led to the approvals of these drugs. Why? Because these patients are known to have a heightened immune system. So therefore, if you give them more drugs that heighten their immune system, maybe that's not going to be so great. It might flare those underlying other comorbidities. And then lastly, if you're on any therapy that requires a steroid dose or an immunosuppressive agent that's equivalent to prednisone 10 or more, you probably shouldn't really go on this therapy, because once again, you already have a heightened immune system. But two, it probably would make these drugs not work very well. And we don't really know whether or not they would be that effective. So after that, I think about, well, can your tumors be resected? So even if you have cancer that's moved to another place, if you meet one of our surgeons like Dr. Rothermel here, and he goes, you know what? I think that's only 1 or 2 spots. I think I can get it. So that's really important to think about, because if you're going to go to a surgery, and patients always ask, well, why can't you just cut it out? There's only a couple spots. Well, yeah, if your surgeon says, yeah, I can cut it out, then that's great. But if they can't, the reason why you wouldn't want to go to surgery is because you might get a complication. One, you don't want any cancer left behind, because then what's the point of the surgery? But two, what if you get a complication and you actually really do need a therapy with me or Dr. Mango later, and now you can't because you have a post-op complication, which we can't predict for, but unfortunately does happen. So if you meet Dr. Rothermel first and he's like, yep, I can cut it out, and or there's a reason why that has to happen, then what I can offer you on our end is therapy with immunotherapy for about a year, for 1 full year after. And the idea of it is that it's a cleanup crew. It cleans up any remaining cells that might be still floating around your body, even though your path report says that all your margins are clean, even though the scans say that there's no other evidence of cancer. We know that patients who had cancers that moved to other places logically have more aggressive disease, and therefore probably need something to help clean and get rid of any other cells that might not be visualized because they just haven't seeded somewhere else. So the immunotherapy agents that are currently approved are single agent pembrolizumab or nivolumab. It improves the recurrence-free survival, meaning that we know that it decreases the risk of your cancer coming back by about half, but it has yet to show whether or not it will actually improve how long you'll actually live for. So when I think about adjuvant therapy, I'll go back to sort of the idea of giving a description to your immune system, right? You're sort of banking on the fact that your immune system can recognize any cell that doesn't look like yourself, with really no description of what that cell even looks like. And we know that that has an improvement because your immune system can do those functions. That's what it's born to do. But what if we could give your immune system a roadmap of what to look for? And that's the idea of neoadjuvant therapy, which is a sandwich approach, meaning that we give still 1 full year of therapy, so that's no different. But what if we give immunotherapy before the surgery, so your immune system gets exposed to the tumor before we cut it out? And therefore it learns all the characteristics of that cell, so when we eventually go for that surgery, your immune system, and that cancer is removed, your immune system still has memories of what that cell looks like. And so if it sees it floating around in your body, it goes, ugh, I remember that cell. It really shouldn't be there. Let me now get rid of it. So once again, the purpose of that is to, one, improve patient selection. It also helps us guide subsequent therapies if you can respond to immunotherapy. And also it can potentially make the surgeries easier as well. So approved neoadjuvant therapies are going to be, we can either do single agent or double agents. And sort of what like Dr. Schwartz was saying before, when you have double agents, you're going to have more side effects, right? You're probably going to have more efficacy, which you can see here, meaning the outcomes, meaning when you go to surgery, what are the chances that you have no living tumor left in those samples? It's much better. However, you have to look also under the grade 3 side effects, where it's almost double to triple amount as you add more agents. That can delay your surgery potentially. That can also lead to side effects where you might not be able to tolerate, or we might be too nervous to give you therapy after the surgery itself. So those are all things that me and Dr. Mingler are constantly thinking about when we offer these therapies. Okay, so now what if you're an immunotherapy candidate, your tumors can't be resected? What are we thinking now? So we're thinking of, well, now we know you can't get the surgery, that's definitive. So instead of doing 1 year of systemic therapy, we can offer you 2 years of systemic therapy. And the choices are going to be either this doublet, which is ipi-nivo, or nivo-rela, or single agent pembro with nivolumab. So how do we decide what to give? So this is, once again, another big chart, but it's looking at the pivotal trials that led to these drugs approvals. And we know that ipi is our most potent agent, but also our most toxic agent. In that trial, we included patients who also had brain metastasis, meaning that brain lesions, and that was something that was important. And Dr. Schwartz went in more detail, but look at that 10-year survival, and we found that patients were still doing really well, which is remarkable. We were thinking, oh, well, this drug is pretty toxic. Can we find some other targets that might make it a little bit better? So there was a relatively 047 trial that looked at relatlimab, which is just a different target than the ipi, but still using nivo as a backbone. And once again, we still have really good responses, maybe a little bit better tolerability, but this study didn't include patients who had brain lesions. And then lastly, there's also single agent, which once again, a lot more tolerable, but maybe the response rates are lower. So this is, once again, how me and my colleague, Dr. Mangler, think about what agents to choose when patients walk through our door. To make it more simple, this is really what I think about. Are you fit or are you not fit? And then how much tumor do you really have? And do you have a brain lesion? So if you're fit, but you have a lot of tumor and you have a brain lesion, especially if it's symptomatic, I'm really going to try to give you the most effective agent, which is going to be ipi/nivo, if I think you can tolerate it. If you're not so fit, but you still have a lot of tumor and I'm really worried, I'm going to still want to try to give you a doublet. So I'm probably going to lean towards giving you nivo plus relatlimab. If we're saying that you're fit, but your tumor burden is low and you don't have a brain lesion, then once again, we're starting to go downwards. Maybe we can consider just one agent. Maybe we'll give you two, just depending on where the location is. So what if your cancer is not resectable and you're not an immunotherapy candidate? Well, then this is when all those mutations come into play. We send this off with blood and tissue, and we try to see what mutations exist in your cancer and what has been treated already outside of a clinical trial. So this is all standard of care options and what combinations we can give. And so this slide is really to highlight that if you have one of these mutations, we still have a therapy that can target something very specifically for your cancer. And this is what we're really looking for. These results usually take about 7 to 10 days to come back after we send the genetics. And so for patients who have a stage 4 disease, Dr. Mangler and I are sending these right away. So we have them just in case for later on, but we always start with immunotherapy first. And also these drugs, unlike immunotherapy, don't have a finite amount of time that you'll be on them. So they're just until your disease either grows or you can't tolerate them for some reason. And then if you don't have a target, or let's just say that you went through all those lines, you went through immunotherapy, you went through targeted therapy, there is this newer set of drugs out there called TIL therapy or tumor-infiltrating lymphocyte therapy. And this is the idea is that if we take those T cells out of one of those lesions in your body, those T cells should already know what that melanoma really looks like, right? Because it's coming from within that tumor itself. So we extract it, we take those T cells and put it into a lab, give it some extra food and juice and make it grow really, really quickly. And then we give the patients, we admit the patients to the hospital, we give them really high dose chemotherapy, and then we give them back these T cells. And then we see whether or not patients will do better. And we have found that in the phase 3 trial that has 73 patients, that patients really did do better when we gave them this therapy. It's a lot harder of a therapy because it requires high dose chemotherapy. So you have to be really fit to go on to this therapy because all the patients had side effects, fevers, chills, low blood counts from the chemotherapy itself, and it requires an inpatient stay. So this is sort of the newest thing coming out that is available to patients. So it's something that we're opening at our center in the fall, and so we're really, really excited about this. And then lastly, just like Dr. Schwartz alluded to in his presentation, that we do use chemotherapy still, but it's not a great therapy for the treatment of melanoma. And so we usually reserve it once you've gone through lots of different lines of therapy. We never use it first line, meaning like right up front when you first get diagnosed. But it is technically still an option, though we try to lean towards clinical trials before we go towards chemotherapy, just because we know sort of track record that it has already. So the big takeaway point that I hope you got from my talk is that even when melanoma has spread to other parts of your body, you can still do really well. And so that's why we push really hard for patients to go on therapy if they can tolerate it, because we've seen lots of patients that we didn't think were going to do well, do really, really well and become independent again. And our job, me and Dr. Mangler especially, is to get you to tell you why you need to go on therapy, educate you on what therapy we think would be best, but also to get you through your therapy because the toxicities are definitely real and can be hard to manage. But you can still have a great quantity and quality of life, which are the two points that me and Dr. Mangler always try to emphasize when we treat patients, that we want you to live longer, but we also want you to live well during the time that you're with us. Right. Thank you.